Onc Live Insights is a video editorial program produced by Onc Live.
The primary resistance to EGFR drug is well known. We know that the EGFR pathway activates the KRAS, the RAS, the MEK pathway, and we know that the KRAS is a predictive marker for EGFR. So I think that data is very well understood. But as we know, most of the patients who are wild type get EGFR drug, they respond to some degree, then after 4 to 6 months, they stop responding. So the question is, why do they stop responding? So there are many theories and ideas behind the secondary resistance to EGFR drug. And most of the data that's currently out there shows that there can be a new KRAS or NRAS mutation that can occur as patients get treated with the EGFR drug. So that's probably the first point. Second point is that there can be a KRAS amplification, which can actually confer resistance to EGFR drug as well. Third data behind this is that HER2 amplification may play a role in this. Now, last year at ASCO, there was some data that if you have HER2 positive but KRAS wild type, those patients also do not respond to EGFR drug in small studies. So the HER2 amplification may be a primary resistant as well as secondary resistant to EGFR drug. And third but not least, there can be amplification of MET pathway, which can also confer resistance to EGFR drug as well.
Much more is known about EGFR mutations evolutions in non-small cell lung cancer. This is in part because EGFR mutations are the target for tyrosine kinase inhibitors in non-small cell lung cancer. EGFR mutations are not that important in colon cancer. RAS is, but not EGFR mutations. But the whole pathway probably does mutate during treatment, both spontaneously and because of prior therapies. And again, more is known in patients with non-small cell lung cancer, and that's why the issue of liquid biopsies is much more important in those patients in determining next line therapies after erlotinib, for example. But in colon cancer, there has been work looking at mutations and also looking at whether or not one can reuse EGFR agents. I found at least one retrospective study, there are no prospective studies, but at least one retrospective study of about 82 patients coming out of MD Anderson, of patients who had been exposed to EGFR agents, typically as first-line therapy, and then after second, third, or fourth-line therapies, patients were with no other therapies to choose were given either the same drug, cetuximab, or a different drug, panitumumab, and a small number of these patients seemed to respond. And the two clear markers for the ones who would respond in this particular study were what was their response to the therapy in the first place. That kind of makes sense. And the other one was the duration of their response, the duration from the time they stopped their earlier therapy to the time they restarted it. This has also been seen for chemotherapeutic drugs. For example, people have been re-challenged with oxaliplatin or irinotecan after a vacation, if you will, and have been seen to show response. So there seems to be changes in all of these pathways that can occur that can not only cause worse outcomes, but may actually restore sensitivity both to standard chemotherapeutic drugs and to biologics.
One of the great controversies in the management of metastatic colorectal cancer is which biologics to use and when. The simple answer is that if you have a KRAS or all RAS mutated patient, they shouldn't get an EGFR antibody ever, and that's simple. But if it's RAS wild type and all RAS wild type, we have choices, which essentially are bevacizumab or the EGFR antibodies, cetuximab and panitumumab. And what we really don't know is how do we best sequence it? I don't presume to know the answer. I think in the US, you'll see a lot more frontline bevacizumab use. In Europe, frankly, you'll see a lot more EGFR antibody use. Is anybody right or wrong there? No. Because what we know from CLGB 80405, a US study, a large study, is that whether you start with one antibody or the other, you do relatively the same. And moreover, we're getting survivals in the range of 30 months, which is a median is inadequate, but it is 3 times better than what we were doing 10 years ago. So, these antibodies clearly have value, but the truth is I don't know the best way to do it. And I think anyone who presumes to tell you that this is the way to do it, first line, second line, well, they're guessing. We got to stop guessing, and we need more data that actually fundamentally understands what patient's individual tumor is, how it's made up, and which drug is going to work better for that patient.